This is a case of Maisonneuve fracture complex. In this instructional video, I'll go through the vignette provided for you at the beginning of your module. I will go through an approach to ankle radiograph interpretation, and we'll apply those to the images that were provided to you in the imaging file, and then we'll go through the post-module questions together. So we have a 48-year-old male presenting to the emergency department after slipping on ice and twisting his right ankle. He was not able to weight bear after the accident. There is no contributory past medical history, active medications, family history, or social history. On observation, you notice soft tissue swelling along the medial aspect of the ankle. The distal medial malleolus was tender to palpation, and when you were attempting to assess their gait, in the emergency department, the patient was unable to take more than one step. Assessing range of motion was extremely limited due to patient discomfort. So here is an approach to ankle radiograph interpretation. Some people find this mnemonic ABCs helpful for remembering what to look at, especially when you're starting out and new to interpretation of images. So the A stands for alignment, and what you want to be assessing closely is the mortise joint here. So the mortise joint is also referred to as the ankle joint, and it is bound by numerous ligamentous structures that maintain stability of the ankle. So for instance, over here we have the medial clear space, which is held together by medial ligaments, also known as the deltoid ligament. We have the lateral clear space, which is held together by lateral ligaments, and we have the distal tibiofibular syndesmosis over here, which contains 4 ligaments, and all of these ligamentous structures help maintain ankle stability. So you want to make sure that the medial clear space is not widened. You want to make sure that the space between the tibial plafond and the talus is not abnormally widened or abnormally aligned. Next, you want to check the lateral clear space, and lastly, the space here with the distal tibiofibular syndesmosis. When the mortise joint is in proper alignment, we say that it's congruent. Next, you have something called Bowler's angle, which can be drawn on the lateral radiograph, and that's used to assess for a calcaneal fracture. So when the Bowler's angle is reduced, typically under 20 degrees, that's when you would scrutinize the calcaneus more closely and perhaps send for an additional axial radiographic view. Next, Bowler's angle is related to the subtalar joint, which is the connection between the talus and the calcaneus. Next, you want to assess the bones and trace their cortices to look for any disruption to suggest fracture. You can also potentially find osseous lesions that could be benign or malignant. Then you want to assess cartilage, and you can look for an ankle joint effusion either anterior to the talar dome or in Kager's fat pad, which is also known as the pre-Achilles fat pad. And lastly, this S stands for soft tissues and really everything else, so that you can have a look at everything and be systematic in your interpretation. So you could look for soft tissue masses, abnormal calcifications, and on the lateral radiograph, you can actually appreciate the Achilles tendon as a dark stripe traveling down the back of the lower leg, coming to articulate with the calcaneus. If you notice any disruption of the Achilles or abnormal widening, then that would suggest an Achilles injury. So applying our approach to our ankle radiographs in the case module, assessing for alignment, I'm immediately drawn to the fact that there is widening of the distal tibiofibular syndesmosis as well as widening of the medial clear space. So therefore we cannot say that our mortise joint is congruent. However, the lateral clear space appears to be in appropriate alignment. And then looking here at the subtalar joint, this looks to also be an appropriate alignment as well. Next, when we assess our bones, my eye is drawn to the fact that there is evidence of cortical disruption. We see this lucent line traveling through the medial malleolus. And then it's important to assess the remaining visible osseous structures, including the tarsals and visible metatarsals. And particularly, it's important to assess the base of the fifth metatarsal here because sometimes there can be avulsion fractures, also given the eponym a Jones fracture. When you're assessing for ankle joint effusion, again, you can assess anterior to the talar domes or in the pre-Achilles or Kager's fat pad. Lastly, assessing the soft tissues, again, you would look for any edema or soft tissue masses or abnormal calcifications. And here is where you can see the Achilles on the tendon on the lateral radiograph as this dark stripe coming down here. So if you notice, again, any disruption to the contour of the Achilles or abnormal widening, that can raise your suspicion for an Achilles injury, which can be further evaluated with another imaging modality such as MRI. So to summarize our findings, we have a fracture of the medial malleolus with resultant widening of the medial clear space. We have widening of the distal tibiofibular syndesmosis. So widening of these regions is suggestive of associated ligamentous injury or disruption, and we see that the tibia is subluxated medially. This is an unstable ankle injury and should prompt you to order radiographs of the tibia and fibula to look for a proximal fibular fracture, also known as the Maisonneuve fracture complex. So question 1, based on the Ottawa ankle rules, why was an ankle x-ray indicated for this patient? And the answer is inability to weight bear and tenderness of the medial malleolus. So according to the Ottawa ankle rules, an ankle radiograph is indicated if there is pain in the malleolar region with any of the following: tenderness at the posterior edge of the distal 6 centimeters or tip of the lateral malleolus, bone tenderness at the posterior edge of the distal 6 centimeters or tip of the medial malleolus, and inability to weight bear for at least 4 steps immediately after injury and at time of assessment. So if we can recall back to our stem, we notice that the patient had tenderness at the medial malleolus, and they were only able to take 1 step in the emergency department when attempting to assess their gait. Anatomically, where is the fracture on the ankle radiographs? As we saw before, when we were going through our systematic interpretation, the fracture was located in the medial malleolus. And this is where knowing and understanding your anatomy is crucial to radiographic interpretation. So we see over here that this is labeled as the medial malleolus, and when we apply that to our image here on the right, we can see that that's where the fracture line is. If the imaging file that you were provided only contained ankle images, why would a radiograph of the tibia and fibula be indicated? As we discussed before, we would be concerned for an associated proximal fibular fracture, also known as the Maisonneuve fracture complex. So we know that C is wrong because the concern is not for a proximal tibial fracture, and a Monteggia fracture is the eponym for a fracture of the proximal ulna with associated dislocation of the radial head. And lastly, a Sagan fracture is a type of avulsion fracture of the lateral tibial plateau. So to summarize what we discussed before, a Maisonneuve fracture involves either a fracture of the medial malleolus and or widening of the medial clear space due to deltoid ligament injury, and widening of the distal tibiofibular syndesmosis, all of which we saw on our radiograph for this patient. And lastly, when we do the tib-fib radiographs, we would expect a fracture of the proximal fibula. And when we look at the imaging provided in your module, we can notice this obliquely oriented fracture of the proximal fibular shaft. Lastly, which statements about the AP ankle radiograph provided to you is correct? So we know that A is wrong, because we cannot say that the mortise joint is congruent, because we have widening of this space here and this space here. However, we notice that the lateral clear space is in appropriate alignment, meaning that the fibula is still articulating well with the talus. So we know that B is incorrect, because it's actually the tibia that is subluxated medially. And because the fibula is articulating well with the talus, there is no widening of this lateral clear space, and what we have is widening of the interosseous space. And that concludes our case on Maisonneuve fracture complex.